I really want to continue with Dr. Smatanov presentation, and then maybe we can switch to the presentation that was not able to start. So, Dr. Smatanov is going to share the experience when there is a problem to open the stents.
So can I play it from my laptop? It's okay? Okay. See it's working. Okay, so my name is Svetozar Matanov. I work at University Hospital St. Ivan Rilsky, and I would like to thank and I want to express my gratitude to stand before you today and to share our experience in dealing with some of the critically deformed flow diverter stents. I would also take a moment to thank Professor Sirakov and Dr. Sirakov for their mentorship and for working with them in this very large field of neurointerventions. With that, let's begin. We all know how flow diverters were developed and what's their purpose. They were initially developed for treating mainly large ICA aneurysms with a wide neck. Currently, flow diverters are used for treating mainly distal, can be used for treating distal aneurysms beyond the circle of Willis, also fusiform and dissecting aneurysms, also bifurcation aneurysms. They have also off-label use in treating ruptured cases, and of course, they are a final institution for treating aneurysm recurrence or aneurysms that have incomplete occlusion. The key advancements of what is currently available, we have systems that are low profile, we have systems that have surface modification and flexible designs. But that being said, flow diverters are not always perfect. But let's share you some cases that my colleagues have shown. How would you treat this aneurysm in other ways? It's a giant cavernous aneurysm with fully reconstructed, as you can see in this slide, parent artery. Also, this case, I will skip the cases quickly because you've already seen them. Also, this left ICA giant cavernous aneurysm with a fully reconstructed parent artery. Do they work also in large MC aneurysms? Of course they do. This is a reconstructed artery. This MRI showed at 6 months follow-up with fully reconstructed artery. The patient was asymptomatic. We sometimes see some occlusions of the bifurcation vessels, but they are always in our center asymptomatic. Also with this similar case, how would you treat it otherwise? I think that there is no other options, or some maybe experienced neurosurgeon can say their expertise, but with a single flow diverter, with a procedure under 30 minutes, you can place a flow diverter in the lower M2 branch, and the aneurysm is gone at 6 months. With that being said, we've all seen some good examples of the flow diverters, but what happened when we encounter some problems. The main technical issues with the flow diverters include their incomplete expansion, their Woma position, their proximal distal narrowing or twisting. We have several complex bailout strategies, which include microcatheter massage, which I haven't included in this slide, which I'm sorry for, balloon angioplasty, additional stents, or stentectomy. This paper briefly summarizes the major neurovascular societies classification that is endorsed by the major endovascular societies, which classifies the flow diverter deformities into 4 main types, meaning foreshortening, fish mouthing, braid bump, and braid collapse. So now we have the names for these issues. Can we do something to solve them? We've seen that we can place a balloon, we can play with a microcatheter, but with some caution, of course, we can also try to place another stent. But what if you have a device that can be applied with a focal radial force, which is retrievable and doesn't occlude the artery? Now let's talk about Comaneci. You may know that what's Comaneci. Comaneci is a device manufactured by Rapid Medical. It's a wire-based stent-like device. It has adjustable expansion, meaning that it can be dynamically controlled in real life with this proximal grip handle, which can control the device. It can be collapsed or expanded. It's retrievable after deployment, meaning no need for any antiplatelet therapy, and it's non-occlusive. Comaneci is a non-one-size-fits-all device. It has 3 different versions, different in their length, in their microcatheter compatibility, and the size of the vessels that being treated for. So the main clinical applications of the device include the device was actually manufactured for alternative as for balloon-assisted coiling. It prevents, its main idea is to prevent coil collapse, which we demonstrated in one of the first larger case series, especially in ruptured cases, which my team managed to publish in leading journals. The device also can be used for treating pharmacoresistant vasospasm, and it also has off-label use in thrombectomy. What are the advantages, or why should we use this device instead of a balloon? The device is non-occlusive, it's adjustable expansion, it's easier to navigate in tortuous vessel, and one important thing, if you're using smaller French catheters, no need for an additional microcatheter. Unlike a balloon, Comaneci can be delivered through the same microcatheter used for a flow diverter. So, now, what if we could use the device to fix some deformed flow diverter stents? This twisted one, this collapsed, or this stenotic stent. Before we jump onto the cases, I would like to share briefly our data. From the period of 3 years, started from 2022 to 2025, we included 17 patients treated by Comaneci device, Comaneci-assisted flow diverter optimization. Mainly the aneurysms were located on the ICA. We used different flow diverters, mainly P64 Classic, that's the flow diverter that we like in our department. Most of the cases were treated by Comaneci 21 because of the ICA location. 14 of the patients received 100% of optimization. 3 patients, their wall position improved, but wasn't optimal due to the tortuous anatomy maybe, or the large size of the aneurysms. Important to note that there were no device-related complications. And with that said, let's continue to some of our cases. This is a patient with an ACOM aneurysm. As you can see, the aneurysm is kind of difficult to treat otherwise. The patient has a hypoplastic A1 segment on the right side. So we decided to place a flow diverter from the ipsilateral to contralateral ACA. And as we deploy the flow diverter, you can see that there is some twisting at the middle part of the stent. Of course, we first tried some light maneuvers, like passing a microcatheter. We established a better position, but we were not so happy with the results. That's why we passed the Comaneci device, in this case a Comaneci 17 device. We gradually expanded the Comaneci through the whole length of the stent. And as you can see, the final result is a beautifully opposed flow diverter. The next case is an MC aneurysm, recanalized previously code. As you can see from this slide on the roadmap, the navigation is quite difficult. There is some angulation of the vessels. This is the microcatheter positioning, and of course, when we deliver the flow diverter, this part of the flow diverter is not well opposed. What we did, we passed Comaneci 17 again in this case, and we managed to achieve not optimal but suboptimal expansion, which I cannot show you because the patient hasn't come to a follow-up yet. Another patient with an ophthalmic aneurysm. You know that this aneurysm is kind of difficult if you're not using sophisticated imaging to decide if there is some twisting or some stenosis of the stent, but I'll show you that in this case, this is the diameter of the stent on the lateral, almost significant stenosis of the stent. What we did was pass a Comaneci 21 in this case, and I'll show you the final result. I hope you see on this image almost complete or full expansion, as we can appreciate on the fluoroscopic image. And the case that Dr. Shirakov presented of this aneurysm with some intracranial stenosis at the level of the neck. this thing here. We already knew that the stent wasn't going to open properly. That's why we placed a Comaneci device. And as you can see at the follow-up, there was at 2 months, the vessel is absolutely remodeled. Ideally, what are the final thoughts? Ideally, we would always place a flow diverter perfectly, but in reality, you all know that this is not the case. Malposition, deformation, and suboptimal expansion happen, and that's why they require some solutions. Comaneci provides a real-time adaptable tool for intra-procedural optimization. It's not a replacement, but a useful adjunct in our charging cases. We managed to demonstrate its feasibility and safety in 2 papers that we managed to publish. And also, I would like to leave these questions to you. Are we asking the right questions? Even if a flow diverter looks well up also on DSA, VASO-CT sometimes tells a different story, which is appreciated by this great paper of the utility of VASO-CT of intracranial treated with flow diverter stents. Should we perform angioplasty or VASO-CT in every patient with flow diverters? Is malposition a question of technique, device design, vessel anatomy, or something that we don't fully understand yet? Are we missing a key factor in the flow diverter deployment? With that, I would like to thank you for your attention.
Thank you for your wonderful presentation. It is absolutely, as you said, in many scenarios, you think that the stent will land in some place, but you end up in a totally other place, fish mouthing. So you need to have possibilities to open, sometimes in instance stenosis. There are different options, but obviously Comaneci works very well. I know the experience of Professor Sirakov with Comaneci, it's great. Any questions from the audience? Thank you again.